We're now live now, Jeremy.
Okay, thanks, Gary. Let's wait just a bit. Hopefully students will come and show up. It's the end of the term on our end, so they've just finished their classes on Friday, so hopefully they'll still join us. Yeah, so people are slowly coming. I'll give it 2-3 minutes and I'll start. Okay, good afternoon. So I'll slowly start the presentation while people connect to the session and to Zoom. So let me first welcome you to the session, and in particular our speakers. We are particularly delighted to use this IDS member seminar as a launch of the IDS Bulletin that I just co-edited with Dolf on Humanitarianism and COVID-19, structural dilemmas, fault lines, and new perspectives. So we'll have 3 contributions in today's seminar, presenting 3 chapters, but we encourage you to go and read through the entire issue. In terms of acknowledgement, I would like first to thank our funder, the FCDO, through the COVID Collective. And basically the idea of the COVID Collective, it was set up to offer a rapid social science research response to inform decision-making on some of the most pressing COVID-19 related development challenges. So with Dolf, we prepared an editorial of the issue, and I would like really to emphasize 3 preliminary points before I invite the other speakers. And also, I don't want to share the whole points and encourage you to read them. It's just a little taster, if you like. I think the first point is quite obvious, but it's worth repeating, is that the sort of economic and social impact of the pandemic on forcibly displaced person and others has been severe. I just pulled out a quote of editorial which basically emphasized that COVID-19 was less the pathogen that fundamentally altered everyday lives, but rather an additional stress that reinforced pre-existing forms of precarity, which is not surprising. But as a consequence, is that there was sort of an amplified need for humanitarian assistance globally. The second point is really that at the same time, while you could describe this sort of increasing need and this increasing precarity, there was another worrying trend, which was the sort of increasing inclusion and exceptionalism associated with the sort of eroding politics of protection and human rights for refugees, migrants, and IDPs, with much stricter border and migration policies across the world. A couple of examples to give you, you could find more bigger sort of narratives and discourses around that frame essentially refugees as burden to the state and scapegoat essentially people on the move as seen as the one responsible for spreading the virus. And the other one is obviously the increasing human and financial toll of the pandemic that has resulted in increasing tensions between displaced population and host communities. And then finally, the third point that I really wanted to emphasize, and it is one of the paradox, is that we've got increasing need, tighter protection measures under sort of exceptional circumstances. But structurally, I think that sort of COVID-19 has severely tested, the humanitarian system in its ability to provide care and protection in crisis conditions. And what was particularly interesting in this bulletin, and as we'll discuss now in the different presentation, where sort of different contributors have highlighted the importance of local forms of solidarities and mutual assistance, which is interesting because it ties into one of the sort of important point in the humanitarian system, which is the localization agenda. And one of the key questions, I think, is to what extent this COVID-19 and the renewed focus on the role of local actors offers really an opportunity to turn the rhetoric of the localization agenda into action and provide more funding and support and recognition for these national and local humanitarian actors. So I think that's one of the sort of key points in some ways. A system under stress, alternative systems being developed, and to what extent we can build on these. So now I'm going to turn to the presenters. The first presenters is Lily and Sarah, that are essentially going to talk about the effect on contraceptive services across the humanitarian development nexus. So the floor is yours. Thank you very much.
Thanks very much, and thanks very much for having us. My name is Lily Jacobi, and I'm an advisor for sexual and reproductive health and research with the Women's Refugee Commission, and I'll be presenting on the article I authored with my colleague, Sarah Rich, Associate Director for Sexual and Reproductive Health, COVID-19's effects on contraceptive services across the humanitarian development nexus. Slide. Contraceptive services are life-saving, and they're part of the standard for a minimum humanitarian health response. The evidence also demonstrates that it is feasible to provide contraceptive services in diverse humanitarian settings, and that diverse affected populations demand and will use contraception. However, contraception continues to be a gap in humanitarian health funding and programming. Slide. To date, there is still limited evidence available on the impact of COVID-19 on contraceptive services in humanitarian settings, although data is coming out more and more all the time. In the fall of 2020, as part of a larger landscaping assessment on contraceptive services in humanitarian settings and across the nexus, the Women's Refugee Commission conducted a series of key informant interviews with stakeholders across humanitarian and development settings to explore the impact of COVID-19 on contraceptive service delivery, different innovations that partners implemented to ensure that contraceptives remained available and accessible, and the different facilitators and barriers that they experienced to contraceptive and sexual and reproductive health service delivery more broadly in COVID-19 preparedness and response. Slide. Thank you. Respondents were identified using purposive and snowball sampling and included representatives of 1 UN agency, 11 international NGOs, 5 national NGOs from various regions, and 3 government health authorities from 3 countries, all of which were in sub-Saharan Africa. 6 interviews were conducted and transcribed in French, and then translated to English for coding and analysis. Data was subjected to thematic analysis using in vivo 12+, and researchers obtained informed consent prior to all interviews. So there's no identifying information included in the article. Slide, please. First, we'll look at some of very broad strokes, the disruptions and challenges that respondents described. Key themes that really emerged in both humanitarian and development settings included the availability of health facilities providers and supplies, and then also community level barriers. Many respondents, again, in both humanitarian and development settings, reported disruptions due to health facilities being closed as a result of lockdowns and movement restrictions, or being converted for COVID-19 response and providers being redirected away from sexual and reproductive health service delivery to COVID-19. And this caused particular disruptions, notably for the delivery of highly effective, long-acting reversible contraceptives like IUDs or intrauterine devices, for example. Many respondents across organizations and settings also reported that contraceptive services were impacted by supply chain disruptions from the international to the local level. And these disruptions increased costs, including shipping costs, and led to stockouts of contraceptive commodities. PPE was also a supplies-related issue. It was prohibitively expensive and/or difficult to obtain, particularly at the outset of the pandemic, which resulted in providers being unable to deliver services even when they had contraceptive commodities on hand. Community level barriers included lockdowns and movement restrictions and fear of visiting health facilities due to the virus, and financial barriers caused by loss of livelihoods coupled with increased transportation and service costs. Slide. However, despite challenges, organizations across humanitarian and development settings innovated and adapted to deliver contraceptive services. And these are really a very high-level sort of summary of the different types of adaptations and innovations that we saw. Respondents across settings described using telemedicine or technology, community-based distribution. So for example, delivering services through community health workers, and task shifting and sharing, including delivery of some contraceptives to pharmacies and dispensaries. Many respondents distributed multi-month supplies for oral pills, condoms, and other short-acting methods to clients to reduce the number of times that they needed to visit the facility. And respondents also reported that stakeholders approved and supported clients to self-administer some methods, like some types of injectable contraceptives. Respondents also reported that integrating contraceptive service delivery with other essential services, like, for example, childhood immunization service delivery, supported uptake and helped reduce the number of times that communities needed to come to the health facility. Slide. The types and extent of disruptions and adaptations really differed across settings and were really highly context dependent. However, several key themes did emerge, including preparedness or lack thereof. Respondents in both humanitarian and development settings reported that governments and their service delivery organizations largely did not have preparedness plans for health prior to the pandemic. And even where there were preparedness plans in place, they didn't anticipate a global pandemic and include measures that were responsive to a pandemic, quite like COVID-19. However, respondents did note that preparedness activities more generally, for example, training staff on delivering sexual and reproductive health services as part of humanitarian response, and strengthening supply chains to ensure stock during emergencies, supported organizations to absorb the shock of COVID-19 and adapt services more quickly and effectively. The prioritization of contraception or lack thereof also impacted service availability, with the majority of respondents perceiving that the prioritization of contraception and sexual and reproductive health by governments and decision makers and other stakeholders to be low or even very low, particularly in the immediate aftermath of the pandemic's onset, when really stringent lockdowns and movement restrictions were put in place. Notably, multiple respondents stated that even where governments recognized the importance of sexual and reproductive health, contraception was particularly neglected, as many do not yet understand that it is in fact a life-saving health service. Slide. And unsurprisingly, COVID-19 did have an impact on the funding environment, and funding plays an important role in determining service availability and accessibility. It was a notable finding that respondents across settings largely spoke really positively about their donors' responses to COVID-19, with many reporting that their donors allowed them flexibility to reallocate funds, for example, to procure PPE, to reconvene or to reconfigure facilities, for example, to address social distancing measures, to ensure service continuity. And while respondents across settings did report that COVID-19 significantly increased operating costs, most did not report having to reallocate funding away from their sexual and reproductive health activities to COVID-19 response activities. However, a small number of respondents did report that donors were not able to follow through on committed funding, and some respondents reported that governments had reallocated funding away from sexual and reproductive health in the health budgets as a result of COVID-19. Slide. Ultimately, the COVID-19 pandemic did negatively affect the availability and accessibility of contraceptive services across humanitarian and development settings. But the pandemic also offers opportunities. It has really underscored the importance of emergency preparedness in all settings, whether stable or humanitarian, and the service delivery innovations and adaptations that were established as part of pandemic response should be institutionalized to continue expanding access to contraception for diverse populations. And again, just to underscore that many respondents reported their perceptions that sexual and reproductive health services, and particularly contraception, were negatively impacted because decision makers did not perceive them to be life-saving or essential. And this finding really points to a critical need to continue building awareness and conducting advocacy among donors, governments, and partners that contraception is a life-saving health service, that it's an essential health service, and it is a human right in all emergencies. As I noted previously, this research initiative was part of a larger mixed methods landscaping assessment of contraceptive services across the humanitarian development nexus and in humanitarian settings. So to learn more about this research, in addition to the IDS article, you can see the full body of work at womensrefugeecommission.org. And thanks all very much.
Fantastic, right on time, brilliant. Thank you very much. So just for the audience, we'll go through the free presentation and then we'll open it for question and answers. And I think there'll be a lot to think about, especially in terms of innovations, their sustainability, their usefulness in terms of the humanitarian system and so on. So the second presentation will focus much more on the health of people with disabilities during the pandemic, and I'll invite Xanthe and Morgan to present.
Thanks so much. So my name is Xanthe Hunt, and I'm a senior researcher at the Institute for Life Course Health Research, which is at Stellenbosch University in South Africa. And I also am a consultant to the World Health Organization. And this paper was put together by myself and my co-author, Morgan Banks, who's also on the course. I'm not sure, Morgan, if you'd just like to wave briefly before I go ahead with the presentation. Great. So as was kind of introduced, our paper looked at the health of people with disabilities in humanitarian settings in the context of the pandemic. And I think kind of one of the key questions was why this population, why these settings, and why we're particularly interested in this kind of nexus. And I think most of our reasoning had to do with the intersecting kind of vulnerabilities and marginalizations that come about as a consequence of the three kind of different pieces of our title, right? So if you think about disability, there are kind of isolatable marginalizations and vulnerabilities to do with being a person with disability, regardless of setting, regardless of kind of context. And the same can be kind of applied to humanitarian settings. If you're a person in a humanitarian setting, across a range of different types of settings, whether you're a person with a disability or not, there are certain challenges and there are certain vulnerabilities, certain risks, and again, kind of layers of potentially exclusion and marginalization. And then if we think about the pandemic, that brings its own set of risks and challenges. And if you're a person with a disability in a humanitarian setting, in the context of this pandemic, you're really sitting kind of at the interstice of these different kind of challenging circumstances. And yet we have a whole lot of literature looking at the discrepant pieces, but not necessarily where they meet. So if we think about disability, for instance, about 15% of the world's population are people with disabilities. It's about 1 billion people. And we know that the likelihood of having a disability if you live in a humanitarian setting is greater. So already there's kind of one intersection between disability and humanitarian settings. But even outside of humanitarian settings and before the context of the pandemic, people with disabilities face challenges in access to basic services, particularly healthcare services, and also challenges in access to specialized services. So with disability, we tend to think about these two streams. Is what is mainstream accessible, and then if something additional is needed, some specialized kind of service like rehabilitation, is that available? And the answer generally in most places is no, not really, for both the mainstream and both what is needed. Then if we look kind of in isolation at humanitarian settings, there are some inherent challenges. These are very dependent on the specific type of setting. So if you're in a refugee camp, if you're looking at kind of settled populations, if you're looking at crises, and then kind of across the spectrum of the type of emergency. But the sorts of things that you might see are limited access to services, particularly healthcare services, very kind of flexible allocation of funding and allocation of resources to different challenges as they arise, which can be really good and important, but can also deprioritize people with kind of long-term conditions. And you can also see higher rates of violence and kind of associated risks and challenges. And then if we think about the COVID-19 pandemic, we all know that there are definitely very immediate effects related to getting COVID and being unwell or potentially dying, but that there are also a host of secondary effects associated with the containment measures mostly, so effects secondary to lockdown and prevention measures. Now, as I kind of said when we started this, there is a lot of literature on disability and its risks. There are lots of literature on humanitarian settings and the challenges. And as the pandemic has kind of evolved, there's been more and more about the pandemic and what it means for people. But there really, at the time of us getting into this, there wasn't a lot that began to look at how these intersect and what that might mean for people. Now, I'm not going to spend a huge amount of time on our methods. We did a scoping review to kind of try and understand what the landscape was like in terms of the literature on people with disabilities in humanitarian settings in the context of the pandemic. And we very quickly realized that there wasn't a lot. So if we look very specifically at our question, there wasn't a huge amount of literature. And part of that had to do with the fact that at the time of writing, this pandemic was still very new. And so people were trying to publish and get information out. And so we quickly realized we're going to have to leverage information that has been generated from past crises and from different kind of combinations of the things we're interested in. So there might be some literature that's on people with disabilities in humanitarian settings. Let's look at that and see what we think can be kind of extrapolated based on what we know about the pandemic and then this body of literature. Similarly, there might be stuff about humanitarian settings in the COVID-19 pandemic, and that would have come out quite quickly, but it might be a little bit silent on disability. And so we came up with this kind of hierarchy of information, and we thought, the tier 1 is what we're really interested in. And eventually there were only about 12 publications that spoke to that. They were all grey literature, and they were all largely from sort of agencies and big international NGOs that have been quite quick to publish guidance. But we also were able to look at the peer-reviewed literature and other kind of sources of information and cobble together, I guess, a sense of what can be said and what can be done. And it was quite interesting in the process of synthesizing that information to sort of weight our conclusions according to the specificity of the information that we were able to gather in a particular area. Now, the way that we started organizing the data as it came in was according to the key challenges that face people with disabilities in the context of humanitarian settings. And again, as the previous speaker also noted, this does vary greatly depending on the particular setting, but there are some very strong kind of cross-cutting themes, and that's what I'm going to try and speak to here. So if we think about the challenges, some of the biggest ones had to do with following preventative measures. So WASH, for instance, is a really kind of big public health intervention, and it's usually quite sort of common in humanitarian settings of a wide variety, but it's particularly important for people with disabilities. So if you think, for instance, if you have a visual impairment, you very often are reliant, particularly in absence of assistive technology, on holding other people or being held by other people when you move around. Similarly, people who have physical impairments, might be in a wheelchair, you often have to hold onto things a lot more than a person without a disability when you're navigating your environment. And so while people with disabilities have a much elevated need for WASH services and risk for contracting COVID by virtue of touching things or not being able to distance from people, there was just an absence of accessible WASH services in humanitarian settings. There was also kind of literature which showed that a lot of the information about the pandemic wasn't accessible. So information for people with disabilities needs to be provided in a range of accessible formats. So you think about Braille, you think about easy read, which is accessible to people with intellectual impairments. And even kind of outside of humanitarian settings, in the highest resourced areas, you weren't seeing accessible information about the pandemic. And so in these settings, there really wasn't a lot of information which was available. And that obviously leads to the spread of kind of misinformation and just a lack of understanding. There's also a lot of sort of structural challenges in accessing specific care related to COVID-19 for people with disabilities. So people with disabilities have much greater risk of infection. This risk is amplified in humanitarian settings where you're very often in very close proximity to other people, sometimes under conditions where sanitation is kind of impaired. And so you have a kind of a higher risk of acquiring COVID-19, a higher risk of getting very sick from it, and yet a limited ability to access the necessary kind of medications due to limitations on mobility. And what you particularly saw was when mandates for kind of social distancing came out, people with disabilities were really left kind of on the back foot and unable to go out and to access what they needed. And often separated from people who were helping them or supporting them or providing care. One of the other kind of things which was, I guess, more emerging when we wrote this, and the evidence is actually just kind of amplified over time, is difficulty in accessing vaccines. So vaccination in many places was rolled out according to kind of a hierarchy of risk. And that risk was usually presented quite crudely according to age categories. And then sort of latterly a little bit about, comorbidities or kind of coexisting conditions. And people with disabilities were often sort of left hanging. They weren't necessarily old, but they weren't necessarily qualifying under the chronic health conditions. And so vaccination rollout was also another area where we saw that, particularly in humanitarian settings, there was this risk of exclusion. And then if you think about populations who are settled outside of camps, if you have a kind of a tenuous legal status, you saw that countries were often requiring identification to arrive when you were going for your vaccine. And so this would leave a whole lot of people kind of unable to access vaccination, even if they were eligible according to one of the criteria. Kind of quite a significant amount of the literature spoke about violence prevention and violence prevention interventions and kind of responses. And I think one of the things that was important to note is that people with disabilities have a higher risk of exposure to violence regardless of the setting. This is then amplified in humanitarian contexts, which have elevated rates of violence kind of regardless. And then what you would see was that there were a lot of myths being kind of perpetuated about how COVID was spread and the sorts of populations who might be more likely to spread it, and misunderstanding that people with disabilities might be sickly people or people who are more likely to spread the virus. And so this kind of combination of things was placing people with disabilities at extremely elevated risk of violence. The other kind of challenges I'm going to go through a little bit more quickly so I can move on to the priority actions, but they really had to do with access to needed healthcare. So I spoke about those two tracks at the beginning of this, where you have mainstream services and is that accessible? But then we also have specialized services. So rehabilitation is a good example. And what you saw is that those were very quickly kind of deprioritized in emergency settings because resources needed to be allocated to the response, to wash, to try to create social distancing in camps where people were living very closely together. And so rehabilitation services and other kind of routine services were kind of had resources taken away from them and fell away. People also, when there were sort of stay-at-home orders in the context of camps, were unable to access routine services that they might have otherwise done. And then there was quite a significant amount of literature beginning to look at what this might mean, what the pandemic might mean for early identification. So particularly for children with disabilities, they're usually identified in humanitarian settings through parenting groups, which are implemented for parents of young children, but also through routine contacts with the health system or through early childhood care and development centers, so little kind of preschool type centers. And when all of those were shut down due to kind of fear of spreading the virus, these opportunities for healthcare workers and for people who were otherwise kind of trained to identify disability to identify children at risk just completely fell away. And the last kind of challenge area, I guess, exists in terms of mental health. So we have very good evidence now from a number of countries that regardless of where you were, kind of who you were, most people's mental health suffered at one or more points during the pandemic. People kind of oscillate in and out of finding it very difficult, but most people at some point have found it very difficult. And we also know that there's a lot of kind of mental health vulnerability, which exists independently if you're in a humanitarian setting or if you have refugee status. And so the combination of those two things saw a huge uptick in rates of kind of common mental health conditions. If we think about the priority actions, it's possible to disaggregate these according to the challenges, right? So they map quite nicely onto the way that we began to think about the challenges that you'd see. So one of the big takeaways, and this was kind of articulated really early in the literature, and it's taken an extremely long time to see it enacted. And I think there are still challenges in making it happen, but WASH really needs to be made accessible. So this means having, for instance, taps and pumps, which can be operated without the use of your hands, or for people with kind of limited mobility or at different heights, for people with visual impairments. But there's also the need, if you think about preventative measures, for exemptions and alternatives, and for those to be communicated widely. So, for instance, for people with communication difficulties, wearing a mask can be hugely difficult, because if you can't hear, for instance, and you rely on lip reading and everyone's wearing masks, that is, you just completely lose your ability to communicate with the outside world, and that's very challenging. So in that case, an exemption might make sense. But if exemptions aren't publicized and the wider community in, for instance, a refugee camp, in a kind of emergency setting, are not aware of that exemption, it looks like non-compliance on the part of people with disabilities. And that, again, will exacerbate vulnerability to violence, to stigma and discrimination. And so there needs to be this kind of partnership between exemptions and exceptions being made and alternatives being presented, but also those need to be communicated as widely as possible. Another kind of key area is, if we think about information, it needs to be available in accessible formats. And that means making it available particularly in easy read, but also in a range of different languages and in a range of kind of different accessible formats across different languages. When we think about healthcare, you can kind of bundle the mainstream and the kind of specialized healthcare together in terms of what needs to be done in some senses, and that's just kind of get it up and running again and make sure that people don't continue to be unable to access kind of mainstream healthcare that they need, as well as specialized services that they need. But when it comes to the mainstream, one of the really important things is training of staff to be aware of the kind of accommodations that people with disabilities might need in order to come in and access kind of mainstream things, for instance, vaccination, and not perpetuate stigma or create kind of social or attitudinal barriers to accessing already scarce health resources. When we think about access to vaccines, there also needs to be kind of unconditionality or no conditions set on access to vaccination. And this is particularly important for settled populations or people who are immigrants in countries. I know in a lot of African countries, I'm from South Africa, this has been something that's very late to arrive, but once it has, we've seen a kind of a surge in people going to be vaccinated as soon as they didn't have to actually take a South African ID document with them.
Xanthe, sorry to interrupt, it's just in terms of the time.
Cool. I'm going to wrap up really quickly.
Yeah.
I think one of the last kind of general things that we found was that if you look at the way that mental health has been affected, and I think mental health was one of the big cross-cutting themes, the way that mental health problems are usually responded to in humanitarian settings are not always accessible. And there was particularly a widespread use of videos and kind of telecommunications to improve access to mental health services. And these were not always done in a way which was accessible to people with disabilities. So I think accessibility is one of the other key things. That's me.
Yes, sorry. Brilliant, fantastic. So let's move to our third presentation from Tanja, who's going to talk about urban migrants in the Horn of Africa and discuss the notion of lived citizenship and everyday humanitarianism. So Tanja, the floor is yours. Thanks ever so much.
Great, thank you. So my name is Tanja Müller. I'm a professor of political sociology at the Global Development Institute at the University of Manchester, and this paper comes out of a bigger research project on transnational lived citizenship among diasporas in the Horn of Africa, where we focus on 3 cities, Khartoum, Nairobi, and Addis, and compare Eritrean and Ethiopian migrants for Nairobi and Khartoum, and Eritreans in Addis, and their sort of transnational lived citizenship. But because the fieldwork was sort of hampered by this, and we had to move it to virtually, and COVID came, we included questions about COVID and how it changed everyday lives of migrants in these 3 cities into our questions. And this paper is based on that additional question. So in my contribution, I make the following argument, that COVID is exacerbating inequalities and precariousness in the daily lives of migrant communities to different degrees. And at the same time, even where transnational support networks were disrupted, we've seen renewed attention to local support networks and everyday practices of solidarity that actually enforced migrants' agency in the face of adversity that was created by COVID and other issues. And these emerging forms of what I call everyday humanitarianism range from spontaneous to more organized forms. But what unites them is their independence from international humanitarian actors and the local state. So I argue that COVID-19 can serve as an interesting example to rethink the call for localization of humanitarian responses from the perspective of migrant networks and transnational diasporas. Methodologically, the paper is based on the analysis of initial interviews conducted for this wider project. So it's based in concrete on interviews with 16 Eritrean and Ethiopian migrants in Nairobi, 5 Eritrean and Ethiopian migrants in Khartoum, and 8 Eritrean migrants in Addis Ababa. The majority were long-term residents of their respective cities with relevant papers like work permits. Some were recognized urban refugees, others were non-status refugees. But still, most regarded the city they lived in, often for a very prolonged period of time, as a transit destination, and were planning for resettlement, usually in the global north, where in some cases family members already resided. So broadly speaking, COVID-19 combined with the policies pursued to combat its spread, which were quite different in the 3 cities, had multiple repercussions for migrant communities in both material and immaterial terms. These repercussions were intimately linked with migrants' legal or aspired legal status in their respective cities, but also with previous forms of insecurities. So in that sense, COVID was less, as Jeremy actually already mentioned in his introduction, the pathogen that fundamentally altered everyday lives, but it was rather an additional stress that reinforced pre-existing forms of precarity. So in this short talk, I will briefly focus on forms of everyday humanitarianism that emerged and were triggered by COVID. And these forms can be roughly divided into informal and formal means. So the informal means were based usually on mutual support that largely drew on informal networks of peer-to-peer support or local community groups, also involving local faith-based organizations or shared memories of history. More formal or coordinated means drew in, for example, the business community and also in some cases embassies. The latter was predominantly in relation to Ethiopian migrants, and the former, the more informal, more dominant among Eritreans. So I'll now provide two examples from the case of Eritrean migrants. Respondent R, who was made redundant from her job in a boutique due to the pandemic, says, quote, "Till now, I could not get another job. And we receive less remittances because our family who send us money are struggling too. In this difficult time, I admire the social heritage of our people that is embedded in our culture. It helps us share what we have, helping family and friends and even others in our community. That is what is keeping us alive. I wish this culture could last forever. Emotionally, the increasing life challenges are damaging, but the culture of support gives me hope." This was a virtual interview conducted in Addis Ababa in December 2020. Similar thoughts are expressed by respondent S, who says, when looking back at a time with most restrictions in Addis Ababa, I admire, quote, "I admire the compassion of the Eritrean community during this difficult time. I'm proud to be Eritrean. No one was left behind. People were looking after each other. We felt more connected during the pandemic. There was a real sense of community." Again, a virtual interview conducted in March 2021. And now I move to the case of Ethiopian migrants. So in the case of Ethiopian participants, we've seen more coordinated forms of everyday humanitarianism emerging, often driven by business owners or other wealthy members of the Ethiopian migrant community. In Nairobi, for example, reportedly partly coordinated through the Ethiopian embassy, immediate relief to the COVID-19 shock was provided in the form of necessities like flour and sugar for those who lost their work. In addition, money was raised to provide monthly stipends to those affected by unemployment and the loss of other livelihoods. But also on an individual basis, Ethiopian employers often showed compassion with their employees. An example for the latter is provided by respondent E, who works for an Ethiopian compatriot. She says, "Our wages and jobs are not guaranteed by law. We are casual workers. I entirely depend on the mercy of the owner. If she wants, she can fire me anytime. I want to thank her for letting me work when possible. I owe her a lot for the help she gave me during that difficult time." That was a virtual interview conducted in October 2020. So taken together, and to conclude, one can say one conclusion of my paper is that migrant populations, through this interconnectedness of their lives between the country of origin, the country of residence, and the wider transnational social field, should really be better recognized as key actors in imagining different ways to ensure people's well-being. Beyond material resources, when a shock like COVID-19 hits. To do so effectively and potentially via claim making from below in the cities where they reside could really be helped by support by key international humanitarians and other actors, like in this case, UNHCR. And in my example, this support was largely absent, or at least perceived as absent. which also tells a story of its own. Local as well as transnational migrant networks, I think, are too often neglected when considering the localization of humanitarian action. And as my contribution demonstrates in this collection, local support networks and everyday practices of solidarity really enforced migrants' agency in the face of adversity that was exacerbated by COVID-19 in different ways in the three cities. I think these findings also highlight the importance of migrant networks and transnational diasporas to the call for localization of humanitarian responses. And I'll end here and happy to talk more in the Q&A.
Brilliant, fantastic. Brilliant. I encourage people to add their question on the chat. We've also, I can see from the list of attendees, we've also got other contributors to the bulletin, and I also encourage them to also highlight in a snapshot way, their chapter to share with the rest of the audience. I'm going to turn to Dolf now to share a few reflections and then to sort of animate the debate, and I'll be there to help too.
Yes, thank you, Jeremy, and thank you to all the speakers for an exceptionally sort of set of interesting presentations and sort of arguments fostered. It's an unthankful task to try to summarize sort of in a few minutes sort of these very rich papers, and as Jeremy sort of highlighted, I would very much encourage everybody who's listening and your friends to actually look at some of these papers, or at least sort of pick a sample. I mean, I'm trying to distill a couple of key points here, which I was scribbling away while you were presenting. Of course, having sort of read the papers before as a co-editor, there's 3 or 4 points which I wanted to highlight sort of, and again, this is not sort of inclusive necessarily. First of all, there's a point around populations. Secondly, around sort of interventions. Thirdly, there is an issue around sort of data. And fourthly, the point sort of, I think, highlighted particularly in the last presentation is around sort of the role of sort of local actors and sort of including sort of migrant networks. Starting with the first point, I heard certainly in a couple of conversations sort of the issue discussed around sort of the difficulty of actually having data in terms of understanding sort of what effects COVID has had, being such an all-encompassing sort of influence or disruptive factor in all of our lives. Sort of it has been very sort of much challenged also by a sort of absence of data at large. And what we see in this collection of articles is a very pragmatic sort of engagement sort of with COVID sort of in the context, certainly in terms of several articles, in the context of existing research programs, using a range of methodologies to try to interrogate sort of the issues before us. So we've seen some very interesting sort of key informant interviews being used, a very systematic sort of way of scoping, reviewing data around sort of disability, very different in its orientation, but sort of very rigorous in its approach as well. And sort of other sort of articles have actually used actual surveying methodology as well, with, for instance, with displaced populations. So I suppose this just underlines the importance of this research as being fresh, and sort of the importance of researchers at large in terms of trying to further understand what are the multiple consequences of COVID on a range of populations that we care about, and on the way in which the humanitarian system functions as well. Talking about populations, sort of several of the presentations highlighted, and again, sort of within the larger bulletin is an important theme around sort of the differential sort of vulnerability, sometimes multiple, that people have depending on their sort of their identities, how you, regardless of how you frame that, whether that's in terms of legal statuses, in terms of race, ethnicity, having particular health needs and requirements. What has been very clear is that people have been differentially sort of vulnerable and also differentially sort of exposed to the risk of COVID on its own, but also the COVID responses by the state, by fellow citizens, and sort of by other sort of actors and organizations in between. We've heard sort of on several occasions sort of the exacerbation of pre-existing vulnerabilities and structural inequalities being absolutely essential for us to understand on how COVID has played out. So in terms of interventions, we were sort of a couple of points that have issues of information were highlighted, of course, related to data as well. Information being in need of being in suitable formats for people that require particular kinds of services and that try to navigate the effects of COVID while they're dealing with other health issues in their lives. That's just one particular way of looking at information as being provided in the right format. But there's also wider discussion, of course, around information and the infodemics around the information, both information wars around COVID, the responses to COVID, and part and parcel of that the scapegoating of particular population groups as being deemed to be more involved in the spreading of the disease. We've heard that in a couple of these presentations. COVID measures themselves in terms of interventions actually may deliberately or inadvertently deprioritize particular population groups, whether that is people who are lacking legal status and are more or less outside of the view of the health providing services, for instance, or whether it is to deal with people with disabilities, where hierarchies of age were determining who is going to get priority treatment, as we've heard. These measures make choices, and it's important for us to understand how the response by state and humanitarian aid providers themselves are implicated, perhaps in the generation of new vulnerabilities, or perhaps indeed in underlining, or if we are positive, in terms of combating those pre-existing inequalities. We've heard an argument made also around existing infrastructures of health actually often being inadequate. So we're building on these histories on these legacies of deficit, if you wish. But I heard a promising argument made by Xanthe around the role of design, for instance, in actually thinking more in the long term about providing better quality services for people with particular needs. In this case, of course, people with disabilities. So I'm going to wrap up with my last point, which was around the importance, as highlighted also in our editorial piece, the importance of local actors and new forms of emerging, if you like, everyday humanitarianism, as Tanja had highlighted as well in her talk. Absolutely essential in terms of this wider localization agenda that the international humanitarian community has embarked upon, rightly so, but often in a quite constrained manner, where the emphasis still is very much in terms of looking at localization in terms of engaging with the state. So very important, of course, local urban authorities or other forms of local authorities. But actually what our various contributions in the bulletin are showing is that there's a very rich set of non-state support networks that are supporting people in terms of provisioning that in a way at the micro scale, and this is an important limitation, of course, at a localized scale often are able to provide the necessary support to people at risk of not just the disease itself, but its important consequences, social, economic, or otherwise. So further attention to these localized mechanisms of response or organic forms of responding is clearly very important for us to understand and important for the humanitarian system at large to engage better with. So perhaps the last point to raise in this respect is really this issue of well-being. What can these networks actually do better perhaps than the state or better than the humanitarian system? It's actually not just catering to the material requirements of human beings, but also, and this has been highlighted, I think, in several of the articles of the bulletin, their ability to cater to the relational or the subjective well-being elements. So combating people's loneliness, for instance, is a good example in this respect. So I'm going to leave it at that. And I'm sorry if I didn't do justice to all the rich contribution, but again, come back to the bulletin and you'll be able to find a rich seam of further evidence and argument. Thank you.
Yes, brilliant. Thanks, Dolf. Yeah, it's just an encouragement to go and basically read the bulletin, and we look forward to your comments. So are there any comments, questions? As I said, I see that there's at least one person that I know that also wrote an article in the bulletin. But any questions, comments, please? A bit like the COVID, I guess the COVID fatigue, there's a bit of a Zoom fatigue too, I guess. I mean, Brigitte, do you want to take this opportunity? I don't know if you want to share a quick, not presentation, but a quick snapshot of what you did with Philip also. Wow.
Jeremy, there's a question. I was just wondering if there are no further questions, we could of course just open the floor sort of to the panelists to ask questions of one another, or just perhaps sort of pick up on some of the discussion points raised and see if there's sort of scope for further, just, you know, a bit of blue sky thinking.
Oh, I think Brigitte wants to talk, but there. Does it work now?
Yes, it does. Sorry, yes, it does. Thank you. So the article that Philip and I wrote looked at how anti-migrant and anti-refugee discourses and policies flourished during the pandemic, and how they had an impact on access to vaccines for forcibly displaced people. Even in countries where officially people were allowed access to vaccines, often the previous discourse and hostile environment meant that people with a unclear status were worried about accessing health systems, because they didn't know if that meant that they would be then deported and so on. But a really major issue was that at that stage of the pandemic, at least, and I think now, is that a lot of the refugee populations are being hosted by global south countries who just don't have access to the vaccines. So they can't give them to their own populations, let alone forcibly displaced people either. But the access to vaccines also kind of fitted within a bigger picture of a rolling back of refugee rights during the pandemic, including rights to protections and so on. Yeah, so I think I'll stop there.
Brilliant, thanks. So Peter was asking essentially the sort of top three, I'm not sure about the top three overall research question that sort of emerged out of the bulletin that we could be sort of taking forward. And I think one of the sort of most obvious answer is essentially to what extent some of the innovations or some of the different forms of solidarities that emerged towards COVID, to what extent are they sustainable? Are we seeing the beginning of a sort of transformation? Perhaps transformation is perhaps too much of a big word, of the humanitarian system as a result of the pandemic or not? And I think that will probably be a fundamental question, if you like, that emerges from the series of points that were highlighted along the different sectors, along the different geographies, and so on. And I think that is the sort of key one. So yeah, that would be my sort of top research question, which is essentially the sort of sustainability and the transformation of the system as a result of COVID. Yes, that would be my sense. But I invite also other panelists to comment on that.
Okay, I have a comment on that.
How brilliant.
I think it's really interesting to look at these bottom-up initiatives in this particular sense, I call everyday humanitarianism. There are other terms like citizen-led development in a broader debate on that. But I really think it's really important to bring them back to the state and force them upon the state, and not basically leave it to people who are already vulnerable to sustain networks that the state might have withdrawn from, and that also the international system, humanitarian and the wider aid system, has withdrawn from or withdraws from. So for me, that's a key research issue, how those things can make the state actually take its responsibility seriously again, and basically we do not have to rely on these bottom-up forms to that in many ways are also, you know, people pay a price in engaging with them in different ways. Yeah, so that's another issue I find really crucial. And if I may add one, and I really don't want to make this like the top three, but I think another issue is when a crisis hits, be it a pandemic, be it something like the war in Ukraine, for example. I mean, how resilient is actually a system to respond? I mean, I'm aware a lot of I'm sitting in Berlin at the moment, which is very near to Ukraine compared to the UK. In many ways, even though Boris makes you think he's the king of Ukraine. But I do think, I mean, I know from humanitarian actors, from where I sit, and I'm on the board of the sort of wider church humanitarian aid, and sort of we have twice yearly meetings to sort of see what the strategic priorities are to go forward. Is at the moment they respond to Ukraine in a way that actually they have stopped working and they really find troubling, but they don't really have any other means or inventions to do so. And I think with COVID also, it really challenged a lot of ways to do things that were there previously. So another key question for me is, what is sort of the resilience, to use that word that I don't really like, but what built-in mechanisms are there to actually deal with unexpected crises that you can't have forward planning to, in a way that still allows you to keep in working based on the beliefs and the strategies and the things that you have sort of developed over decades often, that have determined your work, and not have to throw them out in an emergency response.
A very good point. Any other points that people want to share with respect to that?
Yeah, thanks. Thanks for that great summary, Dolf, and thanks for this question, Peter. I guess for me, a couple of research questions that rise to the top are, what are the lasting impacts of COVID-19 on women, girls, and marginalized populations? And then also, what are effective strategies to meet their needs in humanitarian settings? So really understanding, like, what are the interventions that have been done and have they worked, and how can they be improved? And then I think for me, a second question that really rises to the top is, what have been the impacts of COVID-19 on the localization agenda within the humanitarian sector, including what have been like the successes in advancing the localization agenda, the challenges, and what are the lessons learned that the humanitarian sector can take forward, you know, as the pandemic continues, or you know, if it ever comes to an end at some point.
Yeah, great questions.
I think it would be interesting to hear what Peter himself thinks the agendas or questions are or should be.
Peter, you're on the spot.
Yeah, thanks. Well, it's always easier to ask the questions than to answer them. That's for sure. But they were really great answers and very thoughtful answers. Thank you. Well, I mean, first of all, just to say congratulations to you all on bringing this together, because I think actually even bringing a publication of this kind together during the pandemic is itself quite challenging. So I think that, you know, it's a real achievement and well done. And I really encourage everyone to read it. I think there's sort of two observations, I guess, that we've seen from the overall work of the COVID Collective, which perhaps are worth sharing, and I think really relate to many of the things which have been discussed. One is that clearly systems which are, you know, particularly health systems in many national contexts, have been stretched to the limit because in many cases they weren't really well prepared for a crisis of this magnitude, and that's a global issue. I mean, we could say that in the UK just as well as we could say for many other countries around the world. And what's very evident is that the health systems have really struggled to provide support and, you know, the kind of access to services needed of many different kinds to those who already sort of fall within the health system. And there are many, many people within any given national context who just don't fall within the kind of the workings of the health system. And it may be because they are distant, proximity, or it could be that they are generally people who are experiencing exclusion or marginalization of different kinds within in any given society. We also know that, again, the COVID Collective's work broadly has indicated that in general, those people who are already marginalized and experience exclusion and particular vulnerabilities were feeling the direct sort of onslaught and impact of the pandemic anyway, and the longer term effects, because they're still often falling outside the existing systems, are likely to be very severe for those same people. So they experience it not only now, but into the future. And I guess one big question is, what kind of structural transformation in the systems are needed, whether it's health or other kinds of public system, which enable people to access services of different kinds, for everyone, so that, to use the SDG language, no one is left behind. So that's a big, broad question. But then there's a second question, which I think we're really interested, as the COVID Collective, we hope with support we're looking forward to from FCDO for another phase, is ground truthing our assumptions about what is actually happening in particular contexts. Because one of the things that the COVID Collective has also shown is that there's a lot of quite large assumptions about what's happening within populations. It could be an entire national population, for example, or it could be within certain groups within a population. And the opportunity to ground truth by engaging with citizens, with communities in specific contexts and learning from them, hearing their lived experience, gaining from their knowledge and experience about how the impact of COVID is affecting them, how they see things going forward. Often what are the innovations that they're creating themselves, or what possibilities they're creating as communities to address some of these challenges which the panelists have spoken about. That ground truthing exercise is challenging to do, particularly, I would say, in contexts of crisis, for example, humanitarian contexts, or where there's conflict. But it seems really important to do, because otherwise we're left with these broad assumptions about what's happening without really understanding the reality that's taking place on the ground. So I think those two things I would just sort of put out there, that they're not sort of research questions themselves, but they're offering almost an arena for questions to arise out of those two big challenges. Thanks.
Thanks, Peter. I was going to start by saying, Annie, I don't want to put you on the spot, but that's clearly what I want to do. And I wondered whether, I know you're back from maternity leave too at one point too, but because you're involved in these social science and humanitarian action, I was wondering whether there's any parallel findings that you have, or that you could share perhaps with the groups that would be interesting to hear. But if you don't worry, but I was just wondering with respect to that. I don't know if you doesn't seem to be working. Well, I'm not sure whether Annie wants to speak anyway. But oh, you can't unmute yourself. Okay. Okay, I don't know if Gary can help with that. You seem to be on. No. Okay, can we? No.
I think everybody who's a host should be able to unmute.
Okay. Okay. Okay, doesn't seem to work. Well, in this case, yeah, in this case. Oh, okay. No worries. No worries. Any other thoughts or comments from from the panel or from the attendees?
I mean, I could add something from my own observation on the ground truthing issue. I think what also was interesting for us, I mean, in this wider research project that's financed by the ESRC I mentioned before, we also have local partners. So I work very closely with a local partner in Nairobi. And we have in parallel done some work on internal migrants in Kenya and the challenges for them, particularly migrants to Nairobi who have often moved out of cities again, more generally. And I think in that work, it was also became clear, of course, the challenges for migrants and refugees from other parts of Africa were not Kenyan, are different. But in many ways, they are not so different. So I think for us, it also really challenged those categories of, that migrants are always a special category, because a lot of the challenges were actually the same for internal migrants. And also part of the responses were the same, parts were others, because, of course, internal migrants who are Kenyan have a piece of land to go back to, which refugees or migrants from somewhere else don't have. But in general, those dynamics were really quite interesting. And I think more generally, it I think shocks like COVID can encourage us to rethink categories we sort of work with and take for granted in some ways, without taking away from that legality and not being legal somewhere, of course, is an issue. Etc. But so I will fully support actually what Peter said, sort of the ground truthing is really important. And even within our 3 cities, it became so clear that the official COVID policies had such a big impact. I mean, Kenya had partly a real lockdown, and that affected people very differently. Khartoum hardly had any lockdown. There were rules on mask wearing and other things. Addis was a bit in between. It was mainly a lockdown for hospitality venues and other venues where people mingle. And that also made a real difference in terms of, so it's really hard to actually compare things in a way without really zoning also into this interlinkages between sort of local government policies, responses, etc., and the room those leave, in addition to the other issues.
Yeah, no, that's a very good point. I'm thinking back to my own research project and working in the Ivory Coast and DRC, and what was quite disturbing was working with my colleagues in Ivory Coast, because apart from the first month in March, where they had quite strict measures, you had the impression that they were living back to normal, to be honest, just after a month. And it was very, very different world they were living in at the same time. And besides the whole integration of why some West African countries, the pandemic didn't have the same sort of devastating effects. There's still a lot of question marks about that. But it's true that this sort of differentiated impact and then the differentiated government policies and spaces and so on, was quite disturbing to navigate and to have all of us with our different visions and experiences at the same time. So that was pretty much intriguing. Any other thoughts or comments from the panel?
I just also want to pick up on something that Sarah said. I mean, I think it's really important to really remind us that COVID is not over, and that there will be a long-term impact, that we don't. I mean, even I in my own department, because we had some strange happenings between certain staff, and I just basically said, listen, I think we are all really mentally affected by COVID, even those of us who have maybe a big office at home and are actually in this luxury where we don't have small children to look after, which of course a lot of people have, or have caring responsibilities or whatever. And I think there will be a long-term impact mentally, psychologically, and in other forms of well-being that we will only really know about in maybe 10 years' time. And when we look back and see how things have evolved. And I think it's really, really important to keep that in mind. And I think it was really good to get this piece out, and also some other sort of quite immediate, quick pieces on, what happened on the ground. But I think it's really important not to forget that this is a very long-term issue, and the impact will be long-term and for years to be there, regardless of whether there will be new mutations or not. And but I think it's just something we need to remind ourselves, in particular in these intangible impacts in terms of mental health and overall well-being.
That is so true. That is so true. Yeah. Yeah. Okay. Okay. Well, I guess we'll close this seminar if we got no more questions or comments from the panel. I would like to thank again everybody that participated and encourage you to read and share the bulletin, because in some ways I would take it very much as a live, immediate document that people can react and build on in some ways, and to have a sort of much sort of deeper analysis and look back at it as just data that was gathered that we just need to look more profoundly on and deeper on. Thanks everybody, and I wish you a lovely afternoon. It was great to meet you. Well, to meet you all virtually. Hopefully we can meet in person quite soon in other events. And it was good to be all together for this event. So thanks again. And yeah, Dolf, do you want to add anything?
I think you summed it up beautifully. But also from my side, it's been wonderful to see you, and hope to meet you in person sometime soon. And thanks for being here with us today.
Yeah, brilliant. Thanks again, everybody, and have a lovely